today. Basically, our protocol here is just like in the past, be nice, don't interrupt, follow the gold ties. And of course, if you decide to leave, make sure you bring your ticket so you can get back in. So today, members, March 25th, we are at 1 p.m. I call this meeting to order for Health, Finance, and Policy, and we have a quorum. And may I have a motion to approve the March 23rd amendment minutes?
So moved.
Okay, we have Vice Chair Ryer moves to approve the minutes of March 23rd. Any discussion about the minutes? Hearing none, those in favor say aye.
Aye.
Those opposed? Motion passed, and the minutes for March 23rd is approved. And our first bill on the agenda is House File 4493. We do have a full agenda, members, and appreciate everybody's cooperation. Testifiers will be speaking for no more than 90 seconds, like we've done before, so point to the point. And I understand Representative Van Binsbergen, will you make a motion to get Representative Baker's bill before the committee?
Thank you, Mr. Chair. Yes, I'll make that motion.
Okay. The representative moves that House File 4493 be recommended to be placed on the general register. We have a bill before us, Representative Baker. Welcome to the committee, and tell us about your bill, please.
Thank you, Representative Backer, Chair Backer, Chair Bierman. Thank you guys for having me today. I missed this committee. Being on the committee before, it's been a long time, I guess a couple of years. I have a really important bill in front of you today, and I know brevity is important. House File 4493 is a new bill that's going to authorize pharmacists to independently prescribe, dispense, and administer FDA-approved Schedule 3, 4, and 5 medications for medication-assisted treatment to care for patients with opioid use disorder, otherwise known as OUD. Every day in Minnesota, across America, people go to bed in the throes of an opioid addiction. Once in a while, they wake up and look in the mirror and say, I'm ready for this change. I can't do this anymore. Unfortunately, we've heard before this committee, often help is not available. Here's where I'm going to stop my notes here, because again, I think that most folks know I lost a great son 15 years ago, and 15 years ago, there was none of this stuff even talked about. How can we expand this best practice ever to try to help people with medicine that will block your brain to get rid of that high that you're so much striving for. This is such a powerful disease. At the time, my son had just heard about this thing called methadone, and it's very effective if you have the ability to do that, but it's very challenging, and you are really become sort of chained to that kind of a life to get that methadone every day, and it's not an easy thing to do. So then along came buprenorphine and Suboxone, and things happened, and now we get to bring it closer to people who want it that day when they're ready to have that. So when they wake up and they say to me, Dad, I've had enough of this. What can we do? And now to know that we could possibly get it closer to our families with our pharmacists is great. So members, I hope that you hear my testifiers today. This is something I'm very excited to bring to you, and I hope that we can make a difference. So Mr. Chair, I'll turn it over to my testifier. Thank
you, Chair Baker. So we have 90 seconds. The first one we have on deck is Jordan Banster, and then right after that, if Robert Cole could also come up, and then after that will be Cammie LaValle. So you're Jordan, I'm assuming. So introduce your name, you got 90 seconds, and you will get a 30-second warning.
Chair and members of the committee, my name is Jordan Bannister. Thank you for the opportunity to testify in support of Representative Baker's House File 4493, permitting independent pharmacists prescribing a buprenorphine to treat opioid use disorder, or OUD. I serve as a board member of the Minnesota Pharmacists Association, and am so proud to represent our work here today. I'm also a clinical pharmacist at CentraCare and manage medications for patients in central Minnesota. While I'm trained in the treatment of OUD, current limitations prevent me from utilizing that expertise under my own license. Not every provider feels comfortable prescribing buprenorphine, and this creates critical gaps in care, especially in our rural communities. Pharmacists are highly trained medication experts who are well-positioned to expand access to life-saving treatment. This issue is also deeply personal to me. My brother's best friend, Michael Peterson, died of an overdose at just 24 years old.
30-second warning.
His death is a powerful reminder of why access to treatment matters. After losing Michael, my younger brother, who gave me his permission to discuss, also was able to get life-saving treatment with buprenorphine, is doing so well. This will allow pharmacists to start or continue buprenorphine for our most vulnerable patients who need it, and also work with our physicians to encourage referral and make sure those patients are cared for. I respectfully ask you to support House File 4493, and I'm happy to try and answer any questions you have. Thank you all so much.
Thank you. And, you know, my daughter's a pharmacist for a hospital, does exactly what you do, but in a different hospital. So Robert Cole, Burning, is he on
Online,
Zoom?
I think.
Yes, I'm here.
There you
Do you
go.
want me to start?
Yes, you got 90 seconds, sir. Thank you. Say
All
your
right.
name and go for it.
My name is Dr. Robert Cole-Peringer. I'm a medical toxicologist, addiction medicine specialist in Duluth, Minnesota at Essentia Health. I also serve as the medical director of a system-wide addiction program, and I'm a member of the MMA Board of Trustees. I am also in recovery and have been sober for 15 years. Buprenorphine saved my life. Taking a step back, opioid and fentanyl overdose is the leading cause of death for people aged 15 to 55. St. Louis County has the highest overdose rate in the state by some margin. We have two medications that keep people with opioid use disorder alive and allow them to live a normal life: buprenorphine and methadone, nothing else. The evidence for their use is profound. Start 3 people on buprenorphine and you save a life. In northern Minnesota, our options are limited. There are only 3 methadone clinics north of the Twin Cities. We are reliant on buprenorphine, which has the added benefit of overdose protection when taken as it should be. There are limited providers comfortable in administering or prescribing these medications in clinics, and many of these patients cannot access these clinics. This is woefully insufficient, particularly in rural Minnesota, where accessibility is the single biggest obstacle preventing patients from being started and maintained on this life-saving medication. Allowing pharmacists to start or administer buprenorphine would be a game changer and substantially improve accessibility. This doesn't replace physician or APP or advanced practice provider visits, it complements them. In addition, the future of buprenorphine administration is long-acting injectables. Pharmacies can store these formulations more easily than clinics. Many pharmacists are capable and willing to administer buprenorphine, sometimes more so than physicians. I wholeheartedly support this bill. My addiction medicine colleagues across the state who lead various healthcare systems, including Dr. Brian Grahan, Dr. Ryan Kelly, Dr. Kurt Devine, Dr. Ingrid Podnieks, and Dr. David Peter, and others also strongly are in support of HF 4493. Lastly, this bill has nothing to do with chronic pain. It targets patients with opioid use disorder, not those with opioid dependence on chronic prescription oral opioid analgesic therapy. These patients will remain unaffected. It focuses on the rural chronic fentanyl user with unstable housing, repeated overdoses, and lack of consistent transportation, not the
Please wrap it up.
chronic pain syndrome managed on chronic or oral opioid therapy. Thank you.
Okay. We also have Cammie LaValle that's on Zoom, and then Todd Hess, if you can come to the testifying table, why we would appreciate it. So we're turning to Cammie. Go ahead, please. State your name and share your testimony.
Thank you. My name is Cammie LaValle, and I just wanted to thank the chairs and the committee for having this opportunity. I wanted to first clarify, none of this testimony is to try to prevent this bill from heading out of committee and passing. I support this bill. I wish it was done years ago. It would have saved many more lives. My testimony is in support of this bill, and there was just some language that I believe may cause some unintended consequences, and that's what I was testifying about. What some people might not be aware of is there's pain patients that already are being impacted at the pharmacy based on their MMEs, based on a NARCS care score, solely based on that. I've actually been denied care by a surgeon, and they cited my NARCS care score. And so what we're just trying to do is, if there was any language that could be clarified to address that a pharmacist can't unilaterally change someone's drug therapy.
30-second warning.
Or use solely MMEs or the PDMP or the NARCS care score to initiate OUD treatment when someone does not have that diagnosis. So that's what it's about. I fully support this bill and what it's behind. I know it's not for chronic pain patients. It's just, it's already happening. I want to prevent further misunderstanding that it's already happening at pharmacies. Thank you so much, and please pass the bill.
Thank you, and I guess we have Todd Hess on Zoom. He's signed up for Zoom. Are you there, Todd?
I'm here.
Okay.
Yes, I'm Todd.
30
Hello,
seconds,
Dr. Todd Hess.
90 seconds. Go for it, Todd.
Okay, you betcha. I'll do it quick. Dr. Todd Hess, boarded in anesthesiology and pain management, been a pain management specialist, Minnesota, 35 years. I also suffer from chronic pain. And I'm really glad that Dr. Robert Cringer did clarify that this is not against pain patients. I am 100% in favor of the bill. Also, I believe it's great, Representative Baker and Chairman. What I'm concerned about, again, is language, to make certain that pain patients aren't somehow hurt by this also. And I think it's more of a language issue to make sure that no unilateral diagnosis of OUD can be made in a pain patient. The reason I bring this up is I've taken a lot of help from patients who have cancer, who have very significant diseases, and pharmacists have told me that I was writing too many opioids when indeed the patient was dying. So I wish that we would not have in it any kind of language that could simply change a protocol or change someone's medications accidentally, or if a pharmacist believes that they're on too many opioids. So if this is strictly for OUD, that
30-second
is
warning.
great. I just want to make absolutely certain that pain patients are also protected. One person's OUD can be another person's life-saving medication. So I think we need to make certain that a unilateral diagnosis of OUD cannot be made on the spot and that pain patients are protected. So a small tweak in the language could help this significantly. Happy to help with that. And indeed, I believe this bill should have been passed years ago. Buprenorphine is indeed life-saving for those with OUD. We just need to protect the pain patients that I serve. Thank you, everybody. Get the bill passed. A small language change would help me significantly. Thank you.
Thank you. Appreciate to the testifiers. Is there anyone in the audience who wishes to testify on House File 4493? Okay, seeing none, I'm not aware of any amendments to House File 4493. Is there any further discussion? Co-Chairman Bierman.
Thank you, Mr. Chair. Thank you, Representative Baker, for bringing the bill forward. I appreciate your work not only on this, but in the ORAC Advisory Council and all the work you've been engaged in the years, and especially like seeing you in health today. So good to see you. And to your testifier, Dr. Bannister, thank you for the conversation yesterday on the very issues that some of the testifiers have spoke about. And I appreciate Representative Baker's willingness to continue to have that conversation as need be in the days ahead. Thank you.
Okay. Representative Bonner.
Thank you. I just wanted to say very briefly, thank you, Representative Baker, for this bill, and thank you to the pharmacists that are really those trusted faces in trusted spaces. This is critical life-saving care delivered at the right time, and it can really make a critical difference. So I just wanted to say thank you for that, and for our pharmacists willing to do this work. Thank you.
Okay, we have two more members here that want to speak, which is great. Vice Chair Reiher.
Thank you, Mr. Chair, and thank you, Chair Baker, for bringing this forward. I am just curious because I don't know that much about this area, and two testifiers brought up the issue of it not getting confused or muddling things for people with chronic pain. Can you just explain so that I get it why this is not a problem for that? Thank you.
Go ahead, please.
Mr. Chair and members, I think that, again, I may not be the one to answer, it might be the doctor here, but I think we have made mistakes. The state has made some mistakes in the past that have sort of overreached and hurt people unintendedly. Again, you heard from Cammie today and others, and I think Co-Chair Bierman and I have had to deal with a lot of those kind of issues in the past. I think that they're just being super, super careful. Again, you've heard a lot of support for the bill. And then again, as Chair Bierman said, I'll continue to work on if there's a couple of words to change it. I have talked to the author in the Senate too. I think we do feel really good where it's at today. But if there's something that we can kind of all come to agree with on this, but in the past, it has created some issues. Nothing in this bill is going to make sure that nobody will be changed a prescription or will, I think, and maybe there's a quick comment you may have too, because I want to make sure I say the right things for you, but Mr. Chair.
Absolutely. Thank you, Mr. Chair and members. Yes, the proposed language specifies pharmacist prescriptive authority for Schedules 3 through 5, specifically for the treatment of opioid use disorder. And there is a required 8-hour DEA training as well that any mid-level practitioner would need to take. That training does not in any way talk about looking at the amount of MME or their pain regimen in regard to switching. In fact, that would go against standard of care, and that would be a sanction by the Board of Pharmacy. They want to make sure we are helping patients, not harming them. Thank you.
Okay, anything else there, Vice Chair Reiher?
Yeah, thank you, Mr. Chair. And so the other clarification is, does the person come to the pharmacist with a diagnosis of opioid use disorder and then can get prescribed? Or is the pharmacist also involved in determining whether that's the appropriate treatment? Thank you.
Go ahead.
Thank you, Chair and Representative. Yes, so this is very similar if they presented to a pharmacy how it would be triaged EMS. The patient would tell you, and we would use their COW scoring or their clinical opioid score to do that. We would not be looking at their chronic pain regimen in any way, shape, or form. This is all based on what the patient's telling us they need. So this would not be forced on any patient. We really respect our pain patients and want them to get the best care too. Thank you.
Anything else?
No, just a final thank you. I appreciate the bill.
Representative Liebling?
Oh, thanks, Mr. Chair. And just following on that question, and I also really appreciate the bill and the intent, and it's great to hear everybody, that everybody supports, and that really gives me a lot of comfort. But I'm just still kind of missing the piece that Representative Reiher was asking about, like, is there a diagnosis involved? And from your answer, it just sounded like it's sort of a self-diagnosis. Is that the idea? I mean, I think that diagnosis thing kind of gets to what that little concern is about it maybe happening in an inappropriate circumstance. Can you address that?
Go ahead,
'Cause I don't
please.
see the word diagnose in the bill.
Right, no.
Right, so I'll give you a specific example if that's helpful and how this would work in a retail setting. So if a patient comes in and says, I'm in withdrawal, I heard you can help me. We would start them on buprenorphine, and at that point, we could also refer them to a physician via telehealth model that Dr. Perringer's actually been working on for regional in the state. At that point, if they needed to come to the pharmacy for ongoing care, we do have point of care testing authority, so we could do urine drug screening and collaborate with those great physicians as needed. So really getting that emergency triage right off the bat and then following up with their MD or mid-level as needed.
Okay.
Okay, thank you, Mr. Chair, and thank you very much for that. So I'm understanding that it's sort of the issue is that they're in withdrawal and they need the buprenorphine for that. So that's great. Thank you very much.
Thank you.
Okay, so thank you. I have that, thank you for sharing that. Any final comments, Chair Baker?
Yeah, just super quick. Great questions. I think the moment here that I wanted to bring up that I love about this bill so much is there's no need to get in the way of, I want help. And they can go to their local white-coated pharmacist that should be nearby. I need help, I'm in withdrawal, I need to get something so I start feeling better again. And it is the worst thing to go through. And if they can get through that day with something new, it gives them a lot of hope. Because if they got to wait 2 or 3 days, many times they don't make it. I can't get sick, I can't keep throwing up, I can't be just in horrible throes of the addiction and the withdrawal. They go to it because it makes them instantly better because their body is withdrawing. So that's the beauty about this bill, is it gives them access to it right away so that they can get help immediately. So I appreciate your help, members, and thank you very much.
Thank you. Representative Perryman moves that House File 4493 be recommended to be placed on the general register. All those in favor of this motion say aye. Aye. All those opposed say nay. The motion does prevail, and House File 4493 is recommended to be placed on the general register. Our next bill that we have is House File 3133. Members are go. This one should be a quick one, 5 minutes or so. Representative Franson, would you like to move House File 3133 to be recommended to be placed on the general register?
Yes, Mr. Chair.
Okay. And you would like to move that House File 3133 get placed before the committee and then the general register. Make sure I do that right.
Yes.
We have the bill before us. Representative Franson, tell us about your bill, please.
A very simple bill, members, 5 minutes or less. Thank you. This bill, House File 3133, would make physicians and medical residents in the areas of emergency medicine and hospitalist medicine eligible for loan forgiveness under the Health Professional Education Loan Forgiveness Program. This bill was brought to you by Alamere Health in Douglas County, which is located in Alexandria, Minnesota, the city that is easy to get to and hard to leave.
Okay. Was that a commercial, Representative Franson?
Absolutely.
Okay, we have one testifier, Edward Rife. Thank you for the correction, Representative Franson. So 90 seconds, please, and state your name and share us your testimony.
Thank you, Mr. Chair, and members of the committee. My name is Eddie Rife. I'm the Director of Community Relations and Development at Alamere Health in Alexandria, where I also serve as our primary physician recruiter. We are committed to ensuring every Minnesotan, especially in our rural and medically underserved communities, has timely access to high-quality care. The Minnesota Health Professional Loan Forgiveness Program is a proven tool for recruiting and retaining physicians, yet current eligibility excludes emergency medicine and hospitalist physicians. As a PPS facility with one of the busiest Level 3 trauma centers in the state, we rely on our emergency medicine and hospitalist physicians to stabilize patients in the ER, manage admissions, coordinate discharges, and serve as the medical home when no one else is available. These physicians in their respective specialties are currently not eligible to qualify for the Minnesota Health Professional Loan Forgiveness Program. House File 3133 simply updates the statute to reflect this reality by adding emergency medicine and hospitalist physicians to the eligible list. It makes the program truly inclusive of all providers delivering primary care in rural Minnesota. The modest change will strengthen recruitment and retention where it matters most, helping us keep talented physicians in our communities and protect 24/7 emergency and inpatient services. Alamere Health and the broader rural health community strongly support advancing House File 3133. Thank you for your leadership on rural health access, and I'm happy to answer any questions.
Okay, is there anybody in the audience who wish to testify on House File 3133? I am not aware of any amendments to House File 3133. Is there any further discussion on this bill? Oh, I'm sorry, did not see you. Go ahead, 90 seconds, please. State your name and share your testimony.
I'm Nathaniel M. Olson, the disability advocate for the state of Minnesota. I'm glad I'm here again. Thank you, guys. Thank you, Representative Mary, for introducing this bill. I have to actually agree with this bill because I'm on Medicaid, and literally Atlanta Health decided that they wanted to send my bill to collections, and I do not have $230 to pay for my medical bill that I had services at the hospital for, and I'm wondering, why do I have to pay a $230 bill when I am on Medicaid? So this bill is going to help that I can get it forgiven, because a lot of people like us that are self-employed or on SSI don't make a lot of money, and we don't have money around to have bills to pay. And I literally had bills up to $525, and I had to call my insurance and say, hey.
30-second warning.
Oh, that doesn't matter? Sorry, my bad. But I do agree with the bill. Once I made a mistake in my life. But no, thank you. I mean, I hope we can get more bills out there that would do that, but my bad. So I'm sorry about that. Thank you, sir.
Okay, thank you. Do we have any other people in the audience who would like to testify? Okay, any discussion to this bill, members? Okay. Seeing none, is Representative Franson moves that House File 3133 be recommended to be placed on the general register. All those in favor of the motion say aye. Aye. All those opposed say nay. The motion does prevail, and House File 3133 is recommended to be placed on the general register. We now have Chair Schomacker is up on deck. I believe this one should also go rather quickly, 5 minutes or so. House File 4595. Representative Schomacker, would you like to move House File 4595 before the committee?
Yes, Mr. Chair, I move that House File 4595 be moved before the committee.
And would you also like to move that House File 4595 be recommended to be placed on the general register?
Even better, Mr. Chair, I'd move that House File 4595 be re-referred to the general register.
Well, we're glad that we make you happy. Okay, good. Speak to your bill, please.
Thank you, Mr. Chair and members. Minnesota is facing a shortage of marriage and family therapists, and one barrier is the difficulty in licensed therapists from getting other states. It's the same thing that other states have faced when trying to become licensed in Minnesota. This bill removes unnecessary barriers while maintaining Minnesota's high professional standards through allowing qualified licensed therapists from other states to get more easily licensed in Minnesota. 14 other states have already adopted similar licensure portability standards, including Iowa. I'll now turn it over to my testifier, Leah Seeger, to explain the bill in more detail.
Thank you. State your name in 90 seconds, and thank you for being in front of the committee today.
Thank you, Mr. Chair and members. My name is Leah Seeger. I'm a licensed marriage and family therapist, and I'm here as the president of the Minnesota Association for Marriage and Family Therapy, which represents the professional interests of nearly 3,300 MFTs here in Minnesota. Thank you, Representative Schomacker, and to the committee for hearing this proposal designed to increase access to mental health care services. HF 4595 updates our marriage and family therapy by licensure by reciprocity laws by moving requirements from administrative rule into statute and simplifies the process for qualified out-of-state therapists to become licensed here. The bill eliminates the current 5-year waiting period and removes the equivalent or substantially similar experience requirements that makes licensure difficult for qualified applicants. Instead, the Board of Marriage and Family Therapy would issue a license to any applicant who holds a valid, unrestricted license from another state, is in good standing in their state, passes a background check, and completes Minnesota's ethics exam. Given the size of my profession, a compact would be too costly and complex to implement, as 2 states with the largest MFT populations are notoriously anti-compact. Thus, this licensure by portability is a practical approach that allows Minnesota to maintain full oversight of licensure standards while reducing barriers for qualified providers. This proposal does not lower our standards. Licensed therapists in other states must have graduated from an accredited graduate program, completed supervised clinical experience, and passed the national licensing exam. We have the support of the Mental Health Legislative Network, and we've run this proposal by the Board of Marriage and Family Therapy, who have stated they are neutral. We're not aware of any opposition, and I'm happy to answer any of your questions. Thank you for your time.
Thank you so much, Sarah. I'm not aware of any amendments to House File 4595. Is there any further discussion to this bill? Go ahead, Representative Leland.
Thank you, Mr. Chair. And I just wonder, Representative Schomacker, isn't this just kind of moving our standards for marriage and family therapists to the lowest common denominator of all the states? Like, it seems to me this bill is kind of reminding me of the mortuary science bill that we were talking about the other day, that we have higher standards in Minnesota, and what this bill does is just let people come in and practice here who don't meet our standards. Isn't that kind of what it's doing, or am I misunderstanding it?
Go ahead, Chair Schomacker.
Thank you, Mr. Chair, Representative Liebling. No, I don't believe it's a lowest common denominator kind of piece with that, but I will refer to the testifier to explain some of the differences that we'd be challenged with.
Go ahead.
Thank you, Mr. Chair. This proposal doesn't lower our standards because the therapists coming in from other states would have also graduated from a master's program or a doctor program, completed supervised experience, passed the national licensing exam. And so where there might be minor variations from state to state, we're not lowering our standards here.
Follow-up?
So, yeah, thank you, Mr. Chair. Thank you. I'm glad to know that. I appreciate that. And so, but we're removing some barriers then in this bill, and one of them is having 5 years of equivalent experience. Okay. And then could you just say again, like, what is the other, like, major thing that you're removing that is a barrier to practice for out-of-state practitioners?
Go ahead, please. Answer.
Thank you, Mr. Chair. So when we say we're removing a 5-year waiting period, this is something that's been approved across multiple states as a way for marriage and family therapists to, because we cannot create an interstate licensure compact, it's our mechanism by which we can allow for marriage and family therapists who are qualified in other states to be able to practice here. It's been supported in a number of states, 14 other states actually across the country, and is part of a broader effort with our partners at the AAMFT to create access to care. And what we're removing is the very nebulous language that states equivalent or substantially similar experience that requires somebody from who has an out-of-state licensure to provide paperwork that might not exist. If your supervisor has passed away, if your school doesn't have the ability to provide you with very specific documentation, you have to go through a lot of work to provide documentation of your licensure, whereas there's other documents that you would have to already provide through this licensure by portability agreement.
Okay, Mr. Chair.
Yeah, follow up.
Thank you. No, thank you. I think I got it then. Okay, thanks very much.
Okay. Seeing no further discussion, Representative Schomacker moves that House File 4595 be recommended to be placed on the general register. All those in favor of this motion say aye.
Aye.
All those opposed say nay. The motion does prevail. And House File 4595 is recommended to be placed on the general register. Our next bill, our fourth bill on the docket, is from Representative Nadeau, Vice Chair Nadeau, House File 4143. Our attendant go is about 10 minutes on this bill. Representative Nadeau, would you like to move House File 4143 to get before the committee?
Yes, please.
Okay, good. Representative Nadeau moves that House File 4143 be recommended to be referred to the Committee of Ways and Means. With that, share us their bill.
All right. Thank you, Mr. Chair and members. This is a very, very simple bill, and it hopefully won't take more than 3 minutes. This bill literally blinks off the hospital surcharge for 1 year. For those of you that don't know, hospitals pay 1.56% of revenues to the state general fund. For those of you on the health committee last year, I tried to move this into the healthcare access fund, and we voted on that, and we thought that was a good idea. MMB kind of shut it down for some forecasting reasons. But what I'm trying to do with this bill is there are things that I think that we can do immediately that are going to help our hospital systems. And this will help every hospital across the state, regardless of what district you're in. The cumulative total of this is about $220 million. So I'm just going to take the Owatonna Hospital. They pay $616,841. So if we pass this bill, they will not have to pay that to the state general fund, and every hospital is impacted in the same fashion with one exception, and if you want to ask me about that, I'm happy to talk about it. The downside, the upside of this is that it's an immediate relief that we're providing our hospitals. Immediate. There's nothing that we can do faster to help our hospitals than to not make them pay a surcharge to the general fund. The downside of that is the current 26-27 balance of our budget is $3.734 billion. A revenue loss is how this will have to be attributed of about $220 million. We'll basically reduce that to $3.5 billion. So, yep. It's got a tail that is going to have to be taken care of in the forecast, but it's not like we have targets. We're not spending anything. We can deal with that in the future, and this provides immediate relief to hospitals. And with that, I will take any questions.
Representative Hewitt.
Thank you, Chair Becker, and thank you, Representative Nadeau, for this bill. I'm just having problems. In the tax committee the other day, we heard simply that we can't look at any time we cut revenue that it's not an expense in the budget, and the chairs were pretty predominant on this. And so I'm worried with your own safety net hospital having lots of trouble here. that we're going to be, I mean, this will literally offset the budget. And now that I heard I'm going to be a grandfather soon, I'm really concerned about any time we put stuff in the future to take care of it. So can you kind of help me out there of what, because there's definitely going to be a negative balance on this as far as the tax committee goes. And I get it, hospitals need help too, but I think we use this money in other ways to help those hospitals also. So kind of enlighten me on that.
Representative Nadeau.
Yeah, thank you, Representative Hewitt. There is no direct correlation between when these dollars go into the general fund, whether or not they go into healthcare spending, Medicaid, they can go to transportation, they can go to e-bikes, they can go wherever. We had this discussion last year because I wanted them to be earmarked for healthcare, which is why we wanted to take it to the Healthcare Access Fund. And we learned then that if it goes to the general fund, we lose, those dollars just get commingled with every other resource that the legislature spends. So I disagree with, I guess, with the tax chairs or how I interpreted what you said. There are no targets. You know, there's no target, so we don't have to spend it, and you can tell me that I'm irresponsible for basically making a cut to the forecast, and I am guilty of making a cut to the forecast. I believe that right now, one of the most important things we can do is try to help our hospitals, and this is the quickest way. I mean, we've got other things that we're going to be working on, 340B. This is one small piece that we can put out there for our hospitals.
Follow-up?
I'm good, Chair, thank you.
Okay, we have Representative Liebling.
Yeah, thank you. And thank you for your creative thinking on this. I wonder if you could tell me how much would Mayo Clinic save in a year from this?
Representative Nadeau.
Yes. Representative Backer, Representative Liebling, Mayo Clinic. I'm just going to take the Rochester Mayo Clinic. $41 million. I think I'm reading that right.
Okay, well, Mr. Chair.
Yeah, go ahead.
And Representative Nadeau, well, thanks for that. I'm sure even having made an excess around, I think, $1.5 billion last year, Mayo would appreciate the extra $41 million. But you know, I'm kind of curious, a couple other questions, like, why do it only one time? I mean, if it helps the hospitals, they have needs, why not just get rid of it altogether? Representative Nadeau.
Representative Nadeau.
Thank you, Mr. Chair. Representative Liebling, happy to do it. You know, HR 1 is going to start having some other profound impacts on us as our provider taxes are going to have to be ratcheted back. I am more than happy to, you know, eliminate a 1.56% revenue charge on hospitals into the future. I don't have a problem with that, especially because I can't seem to move it to the Healthcare Access Fund.
Mr. Chair.
Follow-up?
Thanks, Mr. Chair. And, well, I'm sure Mayo would love that, too, and as its revenues continue to grow, which is a great thing for the state, I'm sure that keeping more of its money would be great, but I kind of think we'd be missing that funding for some other pretty important things. And my final real question to you, Representative Nadeau, is why, you know, given that Hennepin County Medical Center is facing an enormous fiscal problem right now, which your number, 220 million, boy, Hennepin County could sure use that money. Why just, why not direct it, you know, you know, why not just, instead of just getting rid of that tax, did you ever think of maybe just directing that money to Hennepin County Medical Center?
Representative Nadeau.
I did, actually, and I didn't think I could get it past this committee. And so, but what I can do is, even though HCMC is having some issues because 80% of their clients are public program patients, unlike almost any other hospital in the state. What I did think we could do is actually help all of our hospitals. I mean, you look at our rural critical access hospitals, and you look at, and they are suffering as well. I mean, we have the rural health transformation funds that are coming in. We don't know when those dollars are going to get there. So no, I'm more than willing to look down the road. This is a 1 year blink off. This is a 1 year plan. I am more than happy to look at, ways that, and we will be in the next weeks, looking at ways that we can focus resources for those hospitals that serve, the highest need patients in the state.
So, Mr. Chair, if I could just finish up
last one,
here.
please.
So thanks for being kind of good-natured about this, Representative Nadeau. I am kind of teasing you a little bit here. But I think I made my point, though. It's a pretty untargeted kind of help. Clearly, our hospitals need help, many of them. Clearly, a particular one right now needs help in the short term, immediate, and a lot of help, and that would be HCMC. But as much as I love Mayo Clinic and, people in my area really love Mayo Clinic, I don't think Mayo needs the gift right now, and I think that money's needed elsewhere. So, thanks.
Okay. Members, we're going to take questions from two more members, Vice Chair Ryer and then Representative Binzenberger.
Thanks, Chair Backer. Thanks, Vice Chair Nadeau. We talked a little bit about this before, but I'm intrigued by the idea and intrigued about the possibility of nuancing it a little bit. To Chair Liebling's point about probably Mayo, I'm going to guess, is the top one on the list. You must have a report there. What are some of the other top, what's the top 3 or 4 in terms of benefiting from this?
Representative Nadeau.
Top 3 or 4, so I'll just go, Abbott is 10.6, Children's is 12.9, these are millions. Other high ones, 41 at Rochester. The 4.8 North Memorial, 2.9 Maple Grove.
So there's a
2.8 Ridgeview. Many of them are, not many, I don't know what the average is, but, you think about Ortonville and Wyndham and Sanford, they're all in the, about $250,000. Perham is 517,000.
Vice Chair.
Thank you.
Ryer.
Thank you, Chair. Thank you, Vice Chair. Yeah, you're going to my second part of my question. And I see there's quite a big drop between 41 million and down into the teens, below teens. And I was interested in the smallest ones because to me, we know HCMC is in crisis, but so are the very small rural hospitals. And I don't see the rationale for blinking it off for everyone, including hospital systems that don't need it, when we could be doing more relief for the smaller ones, or blinking it off, or keeping it and funneling those funds to the smaller and more desperate ones. I think it's safe to use that word, thinking about the state of our hospital system. So my question is, would you consider having ongoing some conversations within this legislative cycle to refine this bill a bit and work on it together so that we could have something that would be most beneficial where it's needed the most?
Representative Nadeau.
I mean, obviously the answer is yes, and thank you. But, this is already a targeted tax. And so to say that it's not targeted is, I guess, not being completely honest. Smaller hospitals that have smaller revenues pay smaller amounts. Large hospitals with large revenues pay large amounts. And Mayo is a large hospital with lots of revenue. They pay a lot. And I don't know who put this legislation together. I don't know who did it. But I do know that it goes to the general fund, and we're taking hospital revenues that they need right now, and we're putting them into the general fund. That's what we're doing. And so this bill, and yep, I'm willing to work with it. If somebody wants to say we need to carve out Mayo, maybe Mayo can come up here and say, we don't need the money. I'm not sure they do or not. I think there's a lot of charity care. I think there's a lot of uncompensated care that these hospitals provide that I think that this would be super helpful with. So I'm willing to, continue to work with people, for sure. There's a lot going on in this thing. But I do want to try to do something to help our hospitals. And, this bill will help Hennepin $8-9 million. Is that gonna, is that significant? No. Is it helpful? Yeah. So thank you, Mr. Chair.
Okay, and our final member is Representative Van Binsberger.
Thank you, Mr. Chair. I'd like to request a roll call.
Okay, roll call has been requested. Go ahead, ask your question.
Okay. This committee, thank you, Representative Nadeau. This committee, I believe, talks a lot about helping our hospitals. And this sure would appear to be a way to provide some immediate relief right away. And so I just appreciate you thinking out of the box. I think maybe you should extend the period even longer than, this is correct me, right? This is a one-time hit. And can you tell me, and it seems fair, everybody is participating in this across the state. I'm curious about my local, because I'm concerned about my local hospitals, and they're working hard. They are on tight budgets, tight margins. I've got critical access hospitals in my district. Can you tell me how much Montevideo would save by this?
Representative Nadeau.
Does it have another name? I don't see.
MCC?
What is it?
MCC? CCM, sorry, CCM.
In what city? Montevideo? I don't
Yeah.
have it. CCM. Is it Centricare?
No. Well,
I can give this to you later.
you can give me
Sorry.
online. I just, obviously it's going to be a substantial amount for any small hospital not having to pay this. So I appreciate the bill.
Okay.
Mr. Chair, just real quickly, can we get a copy of this spreadsheet that Representative Nadeau is referring to, please, for all committee members?
Yep, there's a thumbs up with that. Okay. With a roll,
Mr. Chair.
what?
Mr. Chair, if we're going to vote on this bill and take a roll call vote, I think we need to know how our own hospitals are impacted, and I think it would be good for us to have that information before we take the vote, if we could, because we're not all operating on the same information here.
Okay. A roll call has been called, and we are going to be taking a vote. It's a fair request, but a roll call has been called, and we are going to be taking a vote. So with that, we are going to start the roll call for House File 4143.
Chair Backer,
Yes.
Chair Bierman,
Bierman, no.
Vice Chair Nadeau,
Yes.
Vice Chair Ryder,
No.
Representative Bonner,
Abstain.
Representative Carroll,
No.
Representative DePel,
Aye.
Representative Elkins,
No.
Representative Franson, Representative Franson,
Yes.
Representative Gillman,
Gillman, aye.
Representative Hewitt,
No.
Representative Keeler,
No.
Representative Knudsen,
Yes.
Representative Lee,
No.
Representative Liebling,
No.
Representative Mahamoud,
No.
Representative Perryman,
Aye.
Representative Purcell,
Purcell, no.
Representative Rapinski,
Yes.
Representative Schomacker,
Aye.
Representative Van Binsbergen,
Yes.
Representative Zelenstikar.
Zelensnikar, aye.
So for a bill to pass, we need 12 ayes. Right now, we have 11 ayes, 10 no, and 1 abstain, so the motion does not prevail. Okay, we have our fifth bill to consider, folks. House File 4142. I guess you get to sit in the hot seat again there, Representative Nadeau. Would you like to have this bill moved in front of our committee?
Yes, please.
Okay, we have House File 4142 will be laid over. We have the bill before us. Our goal is to be done with this bill roughly at 2:07. So with that, it's yours. We got 6 testifiers too, so go ahead, Representative Nadeau.
Thank you, Mr. Chair and members. This bill is far more fun than the previous one. So this is about GLP-1s. So GLP-1 drugs were originally developed, remember, to help people with type 2 diabetes manage blood sugar levels, but they've gained widespread attention for their effectiveness as a treatment for obesity. Due to their cost, however, coverage of GLP-1s for obesity treatment in Medicaid, in the ACA marketplace, and most large employer firms remains limited. And GLP-1 coverage in Medicare for treatment of obesity remains prohibited under current law. Obesity drug coverage in Medicaid remains limited, and Minnesota is one of 13 states where Medicaid programs cover GLP-1s for obesity treatment under fee-for-service as of January 2026. When covered, GLP-1s are typically subject to utilization controls such as prior authorization, which can further limit access. Notably, Kaiser's 2025 Medicaid budget survey found 16 state Medicaid programs covered GLP-1s for obesity treatment as of October 2025. However, since then, 4 states, California, New Hampshire, Pennsylvania, and South Carolina, have eliminated coverage for GLP-1s for obesity treatment, likely reflecting the recent state budget challenges and the significant costs associated with this coverage. Medicaid spending on GLP-1s has grown exponentially over the last 5 years, reflecting both an increase in its usage and expanded coverage in many states. This figure includes expenditures on both obesity-indicated GLP-1s and type 2 diabetes indicated GLP-1s prescribed to patients with an obesity diagnosis. In January of 2020, spending on Ozempic, type 2 diabetes indicated GLP-1, was just $4.6 million. At that time, Wegovy hadn't even been introduced. By January of 24, monthly Medicaid spending on Wegovy alone exceeded $51 million, and by October 24, it had grown to $192 million. In Minnesota, the 2024 Medicaid assistant trends for GLP-1s specific to weight loss ranged from 100% to as high as 700%, depending on the program, with an even higher trend seen in the first 3 months of 2025. The average annual cost per patient for GLP-1 treatment is $12,000, with total expenditures now representing more than 12% of Minnesota's overall pharmaceutical costs. In 2021, the legislature removed the weight loss restriction from the drug formulary. At that time, the fiscal note estimated that the cost to DHS would be $1.268 million for FY 24-25. $1.268 million. It's far above that now, and we continue, we've requested fiscal notes from the department, both not just on the spending, but also on the corresponding rebates amounts, but we're still waiting for those. But what we do know is that according to MMB, in the 2025 managed care, the 2025 managed care amendments for rapidly growing utilization and cost trends have totaled for 24-25, just the amendments for the increase was $11.7 million in 24-25, $78.7 million in 26-27, and $87 million in 28 and 29. my bill is not about a discussion whether or not obesity is a chronic disease and condition that needs to be treated. That's not what this is about. This is about balancing or trying to balance the costs of our healthcare system with a very, very increasing cost trend on certain drugs. And this isn't anything new. You know, we currently restrict occupational and physical therapy to kids, to adults under the age of 20. Last year, the governor cut chiropractic care completely out of managed care. And I'm not trying to say that one is comparable to the other. I'm just saying that we do these things in an effort to manage costs. This happens to be a significant cost and a growing trend that I think we need to discuss. We need to understand it. We need to know how much the spend and trend is, and we need to have a more thorough understanding of the corresponding rebates that we're getting for these drugs. And with that, I would love to hear from testifiers, Mr. Chair.
Thank you. We have 5 on Zoom. First one on Zoom, 90 seconds. We have Claudia Fox, and then after Claudia Fox is Carolyn Bramdett. So Claudia, you're on deck. You're on the floor.
Great. Good afternoon, Chairman, members of the committee. I'm Dr. Claudia Fox. I'm a professor of pediatrics and co-director of the Center for Pediatric Obesity Medicine at the University of Minnesota. I've been treating children with obesity for the past 20 years. I'm here to urge you to reject the proposed Medicaid changes to the Medicaid formulary that would prohibit coverage of obesity medications. We must be clear, obesity is not a choice. It's not due to low willpower or poor parenting. It's a chronic biological disease of metabolism. Consider my patient Derek. At age 14, he weighed 270 pounds and already had diabetes and suffered from depression and bullying. Without intervention, Derek faced a lifetime of isolation, dialysis, and heart disease and early death. We started him on a GLP-1, which is standard clinical practice as recommended by the American Academy of Pediatrics.
30-second warning.
He lost 57 pounds and his diabetes test normalized. However, insurance paused coverage and he regained 20 pounds in just 3 months. This is the nature of a chronic disease. When you stop the medicine, the disease recurs. Denying coverage of obesity medications is a parity issue. For example, you wouldn't stop covering chemotherapy for patients who have cancer. To treat obesity as a matter of vanity or fault ignores decades of scientific evidence. I acknowledge that the cost of these medications are high, but the cost of untreated obesity will be higher. I urge you to use your powerful voice to negotiate better prices with drug companies and PBMs rather than forcing your constituents to lose evidence-based health care. Thank you.
Okay, thank you. We have Carolyn Bramdett, and then right after that will be Aaron Kelly.
Thank you. I'm Carolyn Bramante. I'm a general internist and specialize in obesity medicine. I see adult patients at the University of Minnesota. I'm also here to urge you to reject the proposed changes to the Medicaid formulary that would prohibit costs of GLP-1s for treating obesity. And we have other less costly medications for obesity as well. So we don't want to not cover any of them. It's easier to assess the short-term cost savings in adults because they have more costly events. So a recent paper in the Journal of the American Academy of Cardiology used select clinical trial criteria to analyze real-world data. They found that because treatment with Wegovy prevents 20% of heart attacks, treating just 49 patients for 5 years prevents 1 heart attack or stroke. So that's a cost of about $24,000 to prevent 1 heart attack. The cost in Minnesota to insurers of 1 heart attack
30-second warning.
are much higher. $29,000 for just the inpatient care of the acute heart attack, $66,000 for bypass surgery. Lifetime cost is over $140,000. So we are looking at an immediate cost savings of about $63,000, not even considering beyond that first year after the heart attack. So, and this is likely an underestimate of cost savings because that is just one outcome. Treating obesity improves other costly and more common medical conditions like osteoarthritis. So we will probably be saving our state money if we continue to cover obesity treatments and allow doctors to decide the dosing of those treatments for their patients. We often want to use a lower dose, but sometimes insurance doesn't allow that.
Thank you. Aaron Kelly, and then after Aaron Kelly will be Matt Prokop. Aaron.
Thank you, Mr. Chair and committee members. My name is Dr. Aaron Kelly. I'm a professor of pediatrics at the University of Minnesota, where I co-direct the Center for Pediatric Obesity Medicine. I'm a researcher, a clinical trialist, and I'm a leading expert in obesity medications. Obesity is ground zero for countless other health consequences. I could spend 90 minutes talking about them. I won't. High blood pressure, high cholesterol, type 2 diabetes, heart disease, and heart failure. Very expensive diseases to manage. Cancer, sleep apnea, osteoarthritis, kidney disease, liver disease, lower quality of life. These medications do more than just hitting two birds with one stone. It's two birds hitting 100 stones here. We are able to target other diseases and prevent other chronic diseases from emerging. Having led some of the clinical trials, I can tell you that in the studies that we've done,
30-second warning.
medications, we take them away, things come roaring back. The weight comes back, blood pressure comes back, cholesterol comes back, all of these things with veracity. We don't want to be part of this group of states that offered these medications and then took them away. It's devastating for patients. We're better than that. We can find ways to make this work. So I urge you to vote no on this bill.
Thank you. We now have Matt Prokop, and then after that will be Mally Callahan.
Good afternoon, Mr. Chair and members of the committee. My name is Matt Prokop, and I am the Director of State Government Affairs for the American Diabetes Association. The ADA supports comprehensive coverage for obesity treatments, which include access to FDA-approved obesity medications. And as such, we appreciate the opportunity to provide testimony in opposition of House File 4142. Obesity is a costly chronic condition. New data from the ADA shows that obesity increases annual Medicaid costs by approximately $3,800 per person, translating to more than $56 billion in additional annual healthcare expenditures. Treating obesity early can prevent costly health complications and save the state money, especially in our most vulnerable populations like Minnesotans who have Medicaid coverage. The ADA's January 2026 journal article on the costs and benefits of treating obesity among adults in Medicaid include the following positive outcomes for those who have access to obesity
30-second warning.
treatments. $997 million in direct medical cost savings, $874 million in productivity gains, $7 billion in quality of life improvements, and $11.8 billion in mortality reduction value. Reducing coverage that is already available to Medicaid beneficiaries is a step backward, increasing risk for complications and increasing medical costs. As with diabetes, individuals with obesity deserve access to evidence-based treatments that can help improve their health and ultimately drive down healthcare costs. Thank you for your time and consideration, and we respectfully ask the committee to oppose House File 4142. Thank you.
Thank you there. Next is Mally Callahan, and then in person, I understand we have our last testifier is Natalie Eichmann.
Great. Thank you, Mr. Chairman and members of the committee. I'm here on behalf of the Diabetes Patient Advocacy Coalition, or DPAC, an alliance of people working together to support public policy initiatives to improve the lives of people living with and at risk for diabetes and its complications. It's our goal to ensure quality of and access to care, devices, and medications for our community, which include anti-obesity medications, because access to effective obesity therapies is crucial to effectively prevent diabetes. When coverage is cut off, patients don't just lose a drug, they lose a chance to prevent a lifelong, costly disease and its complications. Coverage of these drugs can treat obesity and prevent over 200 comorbidities that are not only expensive to the state, but detrimental to the health, productivity, and quality of life of Minnesotans. We urge you to oppose HF 4142
30-second warning.
and protect access to these preventative, life-changing treatments. Thank you for your time.
And I was wrong, Natalie is also on Zoom. So Natalie Eichmann, you are our last signed up testifier.
Thank you. My name is Natalie Eichman, and I am a board-certified obesity medicine physician assistant practicing here at Body Weight Loss in Minnesota. I'm also the president of the Minnesota Obesity Society, and I am here to respectfully oppose number 4142. Obesity is not a lifestyle choice. It is a chronic, relapsing, multifactorial disease recognized by every major medical organization. It is driven by complex interactions among genetics, biology, environment, and social determinants of health. Left untreated, it significantly increases the risk of diabetes, heart attack, stroke, and cancer. I care for patients who have struggled with this disease for years, often decades. Many have tried repeated lifestyle interventions with limited success, not due to lack of effort, but because their physiology actively resists sustained weight loss, which is part of the disease. Modern anti-obesity medications like GLP-1s are evidence-based, FDA-approved treatments that target the biological mechanisms underlying the disease.
30-second warning.
The problem with obesity is that it is one of the few diseases you can see. It used to be considered cosmetic, but now we know better. These medications are not cosmetic. They are medically necessary and life-changing. If this passes, it would effectively deny access to the most effective treatment for some of our most vulnerable patients. We would never consider withholding treatment for other chronic diseases based on outdated assumptions about personal responsibility. This bill reinforces stigma and creates a two-tiered system where only those who can pay out of pocket can access care, thus widening disparities. I urge you to consider the science, the clinical reality, and the lived experiences of patients. Obesity deserves the same standard of care as any other chronic disease. I respectfully ask you to oppose number 4142. Thank you.
Okay, we have Co-Chair Bierman. You are first on deck.
Thank you, Mr. Chair. Thank you, Representative Nadeau. I just had a question on, as we just heard from a number of testifiers, there's a lot of conditions that weight has, an impact on. And so I was just looking, if it's just solely for weight loss, how much is there an estimate of what we would actually save? Because there's so many commingling conditions that go along with that weight. Doctors would have some latitude in what they're prescribing for around that. Do you have any data on that?
Representative Nadeau.
Yeah, thank you, Mr. Chair. And Representative Bierman, or Chair Bierman, that's a great question. And that's hopefully the information that we're going to get with the, with the technical assistance and the fiscal note on this bill. And you're right, there's all the medical exclusions are still there. This is a carve out solely just for weight loss. So, our pediatrician friends and our doctor friends that are using GLP-1s to help people with comorbidities, they're still going to be able to do those things. This is merely solely just for weight loss alone.
Okay. Mr. Chair, thank you. Thank you for that response, and I'm glad we have a fiscal note coming. I can't believe we don't have a fiscal note, though.
Okay. Members, this is
joke for you.
Members, this is going to be laid over. We have four more members. Four more members on. That's what I'm going to limit it to. So Representative Bonner, you're next, and then Representative Hewitt.
Thank you, Mr. Chair, and thank you to the author. I'm going to respectfully disagree. I think we often talk about prevention as the ultimate here, not only in terms of quality of life, but in terms of the expenses that follow. Because what we're basically saying in this bill is that we're going to wait until you get sick. We're going to wait until you have a whole list of comorbidities, and then we'll let you lose weight. When we could just have you lose weight on the front end, prevent those comorbidities, prevent the additional expenses, give you a better quality of life, and that makes literally no sense. In terms of savings here, we're talking about anywhere between a 5 to 25% body weight reduction can have severe or incredible changes. It can lower the needs for other medications. It can create fewer doctor visits, decreased hospitalization in areas like arthritis, heart disease, diabetes, diabetes alone. it can save, by having these, the ability to do this, you can save up to $5,800 a year on that alone. I think there's a much larger picture here, and there are numerous articles, which I'm sorry I did not bring them with me today, but that are out there that talk about how we are rethinking GLP-1s and their usage because of their ability to prevent all of these other comorbidities down the line. And so I think this bill, while well-intentioned, is extremely short-sighted, and therefore I could not support it.
Okay. Representative Hewitt.
Thank you, Mr. Chair, and thank you, Representative Nadeau. I see where you're going with this, but it's very personal to me. There isn't one of my friends here in the legislature, both sides of the aisle, that haven't asked me what happened to you. Literally, I dropped 90 pounds within 9 months, including my doctor thought I was sick, but I was not. It was a direct result of these medications. Since I've been on these medications, I have no longer taken injectable insulin, which I know saves my insurance company and me quite a substantial sum every month. I know that the factors of going to the doctor and all those things that we heard about, I don't have to reiterate them, are true. I'm a living example of the scientific side of these drugs. And I think that even if you look at these fiscally, the state should really look at investing in these because they're going to keep people in the state that I was in. At 30 years old, when we had our second child, I was in the middle of my physical, and my doctor and I were basically planning out the rest of my life. And the chair knows this, people that drive or work in ambulances don't get a lot of time to eat full dinners or special foods. You eat what you can, and the weight was continuing to come on, and we tried different ways to get rid of it. The doctor clearly told me, John, I can see you seeing the 2 boys graduate from high school, but beyond that, I just don't see it. You will not see your grandchildren. That's extremely personal to me because the changes I made in my life and the changes my care team did for me are now going to allow me to see a grandchild in September. And so that's my personal side, and I don't expect everybody to react to my personal side, but it is my story. But I can see this being just for money and investment reasons for the state, that we should make sure that if a physician, again, not everybody is eligible for this. My son was just turned down, and he has borderline diabetes. And he was turned down, he has insurance and stuff, but he was turned down because he did not meet the requirement. So if we have knowledgeable physicians that are subscribing this, that really feel that this is going to best fit them, I don't know why we would want to limit this and not make this part of our formulary. Thank you, Mr. Chair.
Vice Chair Ryer.
Thank you, Chair Backer. I just have a couple questions. One is, I keep reading articles that as the market advances, we're seeing oral versions and the costs are going down. Have you tracked the per-person cost of administering or receiving this? Because I want to know, I guess before I would have an opinion, whether or not those costs are coming down enough that maybe the data that we're looking at that's retrospective is a bit out of date.
Thank you, Mr.
Representative
Chair.
Nadeau.
Representative Breyer, that's a great question. It's one of the things that the current president is working on with Lilly and others to put it on his Trump RX, website. And so, yes, I do believe those costs are going to continue to go down. But I think, and one of the biggest reasons that I'm doing this is to make sure that once things get put on PDLs, we lose track of where those costs are, like completely. And so all of a sudden you can have a $5,000 drug and it's got a $10,000 rebate, and so it's and again and thank you, Representative Hewitt. I'm sorry I don't mean to cross these things, but I love those stories. Those are important stories. These are important things to do. But I feel like our job is to be as smart as we can about the overall system that we're funding. And we've talked a little bit about the challenges that the hospitals have. So, but back to the specific question, yes, I think those costs are going down, and anecdotally, I think that we're seeing those go down.
Okay, follow-up?
Thank you. Yes, and kind of going to Representative Hewitt's experience and so many other people, my understanding is that people who stop taking the medication then tend to go back to their original well-being. So I like to make sure we've got processes thought through and implications mapped out. So I was just picturing someone who received the GLP-1s as within your framework because they had comorbidities, they were eligible, they got them, and then they lost the weight, didn't have comorbidities anymore. Are they all of a sudden not eligible, and then they get onto a yo-yo thing? What happens to a person who has achieved a higher level of health because of this?
Representative Nadeau.
Yeah, and thank you, and thank you, Representative Ryer. And I'm not obviously a practitioner, so I don't think I can answer that question. But it's part of the reason that I brought this bill. People that go on GLP-1s, if they go, they're on them forever. And if we look at the cost trends of that, and I think that's what I'm trying to look at is, I mean, how much can we afford? How much can we afford? And again, I'm not trying to pick winners and losers. How much can we afford? How much can our system afford? So it's a great question. I don't know the answer to it. This is a system that, I mean, every day we're making, they're making huge breakthroughs in some of these things. And who knows, in 3 years, these GLP-1s might be a penny. And they're all oral, and it's great, and it's no big deal. Who knows? But right now, when I look at MMB's thing, and we're seeing the amendments to just our managed care going from what was once considered to be 1.2 million to north of 90 million. That's something I think we should at least acknowledge and try to address. Try.
Okay.
So, Chair Backer, one more follow-up, please. I don't think that answers the question, but we have all these, it was deferred to a practitioner, and we have all these practitioners on Zoom who might be put in a position of having to, forgive me, take your medicine away. I would like to know what they would do because it's a public policy implication. It's not a nice to know, it's a public policy implication on how we are going to handle the impact of the drugs being prescribed to someone.
Nadeau, any comment on that?
No, I think that as time goes on, we had a lot of testifiers talk about, the reduction in heart attacks. We heard, health outcomes, reductions in heart disease, liver disease. One thing that we do know is that 74% of Americans are obese or overweight. We know that. 53% of kids, 18% of 18-year-olds have fatty liver tissue disease. This is not something that's going to go away, and I don't think we can legislate our way out of there, but I think our job is to try to listen and engage, and that's why this bill is being laid over, and we're going to try to, find out what can we afford. We'll get the numbers back, and if it's something that we can address or should address with, with consultation. I've had numerous conversations with U of M docs on this, and they don't love this bill, by the way, but. It's, their job is to treat kids. Our job is to pay. And if we consume all of our spending in one area, I think we should understand why and how, because this is one component of the challenge that our healthcare system has today. This is one component. That's all.
Okay. A lot of passion with this. We do have other important bills on the agenda. This bill is being laid over. With that, we have Representative Gillman, House File 1724. You're up next. And then we're going to take up House File 2291. Mahamoud. Thank you. So Gillman, our goal is to do this one with 5 minutes. So go ahead, Representative Gillman.
Thank you, Chair and Committee.
for hearing House File 1724. What this bill does is clarifies that direct primary care is not insurance. It's a simple direct agreement between a patient and their doctor. It creates a safe harbor so providers aren't mistakenly regulated under insurance laws. It protects access to affordable care with transparent, flat monthly pricing. Gives patients more choice and control over their health care. Supports small and independent clinics by removing costly regulatory uncertainty. It also encourages preventative care, reducing long-term healthcare costs. It aligns with Minnesota and other states that have already passed similar protections. House File 1724 ensures innovative, affordable care isn't regulated out of existence. Protecting DPC in statute is the safe harbor bill, and it protects the practice even if administrations change. And I just want to put on the record, when we get to it here, that the Minnesota Council of Health Plans are neutral on this bill now. I got a lot of great feedback from them. One thing I do want to get on the record, again, is that these agreements that we have with direct primary care have limits on what is covered and may not have coverage for things like emergency care, unexpected needs such as oncology services, et cetera. So again, we encourage anyone that has direct primary care or insurance, please read what the programs that you're on provide so you know what's covered.
Now, Representative Gillman, we want to make sure you would like to move House File 1720, it is 1724, to get it before the committee.
Yes, please.
Thank you. And so Representative Gillman moves that House File 1724 be recommended to be placed on the general register. And now we have two testifiers for House File 1724. And our first testifier is Dr. What is it? Hey, he's on Zoom. Nadeau, please, are you, hopefully we're close on that. Is he on Zoom?
Hello,
She.
Dr. Najah Mousse, she speaking.
Thank you. Sorry for that. Thank you for your correction. Go ahead, state your name in 90 seconds, please.
Chairman and members of the committee, thank you for your time. My name is Dr. Najah Mousse, testifying for the Minnesota Academy of Family Physicians, representing more than 3,100 family physicians, residents, and medical students statewide. I practice at Frontier Primary Care here in St. Paul. MAFP supports House File 1724. Family physicians are the entry point to Minnesota's healthcare system, offering comprehensive care. However, primary care faces rising administrative burden, workforce shortages, and financial strain, hindering patient access. House File 1724 clarifies direct primary care arrangements. DPC allows patients to pay a fixed monthly fee for primary care services, reducing administrative complexity from insurance billing. For patients, DPC can mean better access, including same-day and next-day appointments,
30-second
visits,
warning.
and easier doctor communication for physicians. It means more time on patient care, less time on paperwork. DPC is a viable model that should remain an option for strengthening primary care access in Minnesota, though it's not suitable for everyone. Thank you for the opportunity to testify, and we respectfully ask for your support of House File 1724. I'd be happy to take any questions. Thank you, Chair.
Thank you so much, ma'am. We have P.J. Mitchell. P.J. Mitchell. Please state your name in 90 seconds, please.
Okay, so what do I say?
Chairs Backer and Bierman, members of the committee, my name is PJ Mitchell, and I'm here to testify on House File 1724 on behalf of the Department of Commerce. The department shares an interest in exploring innovative solutions to make it easier for Minnesotans to access primary care. From recent stakeholder engagement work on this topic, the foremost barriers to receiving care are high out-of-pocket costs and provider supply and availability. Direct primary care and direct primary care-like approaches have emerged in part to help address these barriers, and the department's supportive of these concepts as potential solutions. However, the department has concerns with explicitly carving direct primary care arrangements out of insurance regulation
given the important need for consumer protections within these arrangements. Department does not currently regulate standalone direct primary care arrangements, but codifying direct primary care into statute and excluding it from insurance regulation could inadvertently limit or complicate potential innovation opportunities in
30-second
this
warning.
space. We also have general consumer and market protection concerns, including patient selection issues and potential for consumer harm if arrangements are being inappropriately represented as an alternative to comprehensive health insurance. Thank you for your time. I'm happy to answer questions.
Okay, is there anybody in the audience who wishes to testify on House File 1724? No, we have two. Oh, I only show two. It's only two, because that got removed. Okay, we only have two testifiers. Anybody in the audience who would like to testify?
Can I just, oh, sorry.
Sure, go ahead, Representative Gillman.
I know, thank you so much. Could I just, since you're up here, just address a couple things that he brought up really quick?
Yes, go ahead,
Thank you
Representative
so
Gillman.
much. So from my understanding, direct primary care providers are subject to the general medical malpractice law and medical society discipline. So no need for additional layer of regulations to malpractice, licensure, anything like that is needed. Again, the consumer protections are already in law, and they are practicing under those laws right now. And so contracts are regulated under contract law and consumer protection laws in their statutes right now. Direct primary care is in no way unregulated and is underregulated. This bill would not create any exceptions to the existing rules and regulations that apply to them. I just wanted to comment that and then just ask you, is it already found in statute other places currently? Because we do have direct primary care here in Minnesota right now.
I'd likely have to follow up and take some of that back. Yeah, correct.
Thank you.
Okay. We have Representative Liebling.
Yeah, thank you, Mr. Chair, and thank you, Representative Gillman. And I think this does have some promise and fills a gap. But I just wonder, you're sending it to the General Register, and has this already been through the Commerce Committee?
Yes.
Yes.
And it was bipartisanly passed out of committee. With
Okay, good.
enthusiasm.
Yeah, because, because I do, thanks, Mr. Chair. I think that, I think you're right, there are certain regulations already in place, but I think the concern with the consumer protection is more just around the piece of this where the consumer is paying a fee for something they're going to get in the future. It's not really like insurance, but it has a flavor of that. So you're paying and you're expecting to be able to access some services, and then if you don't get them, kind of what is the protection for that? I think it's more that kind of a concern and not, you're right, physicians are, of course, regulated and, there's all kinds of stuff already in place. But anyway, I hope this can be worked out because I do think it's something that would be good to have in the mix. So, thanks.
Thank you.
Representative Ryer.
Thank you, Chair. And thank you, Representative Gillman, sorry. I appreciate that we had a quick chat about this in the parking lot. It was helpful. And so I'm thinking forward for various reasons. I'm planning to join CGEP. And I'll need to select a primary care clinic as part of that. And I got to admit, this sounds kind of nice because it's like a doctor is kind of access to a gym membership, right? You can go and you can get the care you need. But how do my medical records get integrated?
Representative Gillman.
I would love to phone a friend on that piece really quick. We've got someone here for that. And I'll just, while she's coming up here, I'll just let you know that I personally use this. Again, I have insurance, but I also, our company provides this service, this opportunity, come on up, for our entire company. So we pay for it as the employer for all of our employees. It is affordable. It is an incredible option. Just 2 weeks ago when we had the cough thing running around here, I had a nice healthcare worker come right to the office and make sure that I was okay to stay at work, and it was wonderful. So again, it creates those folks that need accessibility. They can come to your work, to school, or you can go to a facility. You can go to their business. Yeah, great question.
Follow-up?
Actually, I will have a follow-up, but the testifier.
Go ahead.
Okay. My name is Dr. Leslie Surbeck. I'm internal medicine physician. I graduated from the University of Minnesota in 2004. I trained at HCMC in internal medicine, and then I practiced at Health Partners for some time in primary care. In 2021, two partners and I started our direct primary care clinic called Evergreen Primary Care in the Midway neighborhood in St. Paul. And it's been one of the best things I've done in my career. And it's hard to wrap your mind around how simple primary care can be, because in the bigger systems, there's so many forces pulling away from the time that a primary care physician has or provider has with the patient. There's so many other forces. And so, I am here, I want
30-second warning.
answer questions because it is hard to kind of wrap your mind around it. And I also want to say that I think it's truly a bipartisan issue in that everyone needs good primary care, and good primary care can save us a lot of money.
With permission, Chair Backer, my question is, so I have to go, my regular primary care is Park Nicollet, and I choose to go there, and then I also have Evergreen, and for some reason I'm getting care both places. How do my medical records come together?
Great question. So I think, and I may not be totally correct here, but I think it was the high-tech law that said electronic medical records need to be shared. And so if you were to establish with us, you would give me permission to look at your records at Park Nicollet. And we have an account with Park Nicollet, Health Partners, Mayo, all the big systems where we can go and look at all your stuff. Our system is designed so that you wouldn't need that primary care anymore. You would have primary care here, but we could refer you to anywhere, refer you for tests, whatever, and your insurance would still function for those things.
Thank you. Very briefly, do you become the hub if, say, the cough that I had turned out to be probably dramatic, lung cancer?
Yeah.
Do you coordinate then with the specialist? Do you become that primary care hub?
I'm the
then that's my
quarterback.
last question. This is all really helpful and reassuring.
Yeah,
thank
and
you.
I'll let Dr. Slings also answer a few, but that's one of the things that was so frustrating when I was in the big system, was that I didn't have time to help my patients navigate things. So, at Health Partners, I worked part-time but had a very large patient panel. And so when my primary care patient would get sick, they couldn't often even get in to see me. They'd have to go to urgent care or whatnot because I was so overloaded and I was so burnt out. And so I would have time, and now I have time, like if my patients, all the time that have cancer or whatnot, then I can serve as that quarterback and help them navigate, have the time to call other physicians, have the time to really help not only find the right people, but also sometimes with cost. So.
Okay, thank you. Because we have other bills, final comments. Representative Gillman.
I look forward to having more future conversations with this, and I would just ask that you would refer this over House File 1724 to the General Registry.
Okay, so Representative Gillman moves that House File 1724 as amended in Commerce, first engrossment, be recommended to be placed on the General Register. All those in favor say aye. Aye. All those opposed?
No.
Motion prevails. Division, okay. Okay, we have a division. All those in favor, raise your hand. Okay, you counting?
in favor of doing it officially?
All in favor of the bill? A division has been called. Raise your hand if you're in support of House File 1724.
If you're not opposed, just do it, but there's questions that weren't answered. Yes. Yeah, they cut us off in columns too.
Okay, we have 13, so the motion does prevail, and House File 1724, as amended in Commerce, first engrossment, is recommended to be placed on the general register. Okay, members, we are moving to House File 4568, Representative Knudsen, two-year bill. Let me get the... Representative Knudsen would like to move House File 4568 in front of the committee. Representative Knudsen, that is correct. You'd like to have this bill in front of committee.
Correct, that is my motion. Thank you.
Okay, thank you. Representative Knudsen moves that House File 4568 be recommended to, which committee? To Judiciary. So this bill would be moved to Judiciary. To your bill.
Thank you, Chair, and I know we're short on time, so I will make my part short because we have great testifiers here. This bill is the gift of time. That's what this bill's goal is. Where am I going to start? This bill gives parents of children the right to be notified before a do not resuscitate or a decision to not treat their child is made. This bill gives parents a right to find other medical treatment for their child if a doctor is refusing to treat their child. It gives them time to do that. This bill also gives a civil cause of action if these decisions are made without parental notification. I could go on, but we do have great testifiers, so I'm going to turn it over to them if I can.
Okay, go ahead,
Thank you.
testifier. State your name and 90 seconds, please.
Hi, my name is Lori Nelson, and I'm the mother of a child with trisomy 18. When my husband and I were at our final prenatal appointment at Children's of Minnesota, we were told our daughter would not survive. We were told to prepare her for death, not life. But our daughter, Abigail, is alive today. She is 9.5 years old. She is joyful, deeply loved, and her brothers adore her. At that appointment, we asked what could be done to help her live. At first, we were told nothing. So I asked if she didn't have trisomy 18, is there anything that could be done? They said yes. They told us about a medication called prostaglandin. It could help keep the blood flowing in babies with serious heart defects. I asked, would it give time for her family to meet her? They said yes. But it was not offered to us as part of her care. When we left, we made it very clear that we wanted full intervention and that our daughter was full code. Shortly after, I received a phone call from a nurse confirming our wishes. Then she told me that a do not resuscitate DNR order was placed in our daughter's chart, despite our request for full care. From that moment on, we had to constantly check records and advocate to make sure the decisions were not made without us. No family should have to live like that. We were not just fighting for our daughter's life, but we were fighting for the right to her, for her to live. Simon's Law ensures that parents are informed and involved in these decisions. It protects families. Children like Abigail and Simon deserve a chance. Please support Simon's Law. Thank you.
Okay, and then we have Laura Nelson. State your name and 90 seconds, please.
Hi, my name's Mary Kellett. Thank you for having me. I was blessed with a child named Peter. He had trisomy 18. We had a very hard journey with very traumatizing language. We were told that Peter would lead a life of suffering and he would never know us or love us. We were told to abort him and that nobody carried these babies to term and that there were no survivors beyond 2 weeks. We loved Peter and we wanted to do everything we could to help him reach his full potential. When he was born and at the hospital,
he got great care up until 2 days at his life, and then a test came back that said he did have trisomy 18. And then it was recommended that we stop all treatment and just let him go. We found out there were many survivors with trisomy 18, and so when I asked the doctor why he lied to me, telling us that there was only
30-second warning.
no survivors beyond 2 weeks, he said, well, we have to think about resources, and Peter will never contribute to society, and he'll be a horrible, horrible burden to your family. Many deceptive things were told to us, such as he had a fatal heart defect when he didn't. He only needed a PDA ligation, which is a 20-minute procedure to close a blood vessel. Deception has no place in good medical practice, and placing a DNR in a child's chart without the parental knowledge is deceptive, and that has no place in a healthy patient-doctor relationship either. So please pass this law to ensure that doctors and patients have a good, healthy relationship, and language is not deceptive, and this traumatizing experiences don't have to happen for families. Thank you.
Thank you. Is there anyone in the audience who wish to testify on House File 4568? State your name, and you have 90 seconds, and please be germane to the bill.
I'm Nathaniel M. Olson, a disability advocate for the state of Minnesota, and I'm literally so happy that they're here today testifying. But I'm going to say this on the left side of the aisle. If I find out that nobody on the left side of the aisle does not want to vote for this bill, I'm going to be ashamed. Because it doesn't matter what disability we have, we are humans in the state of Minnesota. We do belong. And I'm so sick and tired of our governor just sitting here ignoring the facts of how many people with disabilities in the state of Minnesota could lose their lives. So I'm asking everyone in this committee to vote on this bill, get it to the House floor, and vote yes. Because these people with disabilities are humans too. So Mr. Chair, I would like a roll call on this bill.
We
I'm begging you for a roll call, sir.
Excuse me, you're a testifier. You cannot call for a roll call. You have 20 seconds.
Darn it. But I'm just saying, you guys, disability people are amazing, and I have one myself, and I want this bill to be passed. So please, vote yes. Thank you.
Okay. Thank you. Is there anyone in the audience who wish to testify on House File 4568? Okay, we do have Representative Hewitt for further discussion. Representative Hewitt.
Thank you, Chair Backer, and thank you, Representative Knudsen. I don't know if you know this, or I know Representative Backer and I have worked on this a number of times, but I'm doing a lot of the post bills, which are what we're discussing here, the DNR, DNI orders. And I'm a little lost, and I saw this bill come up, and so I didn't get contacted by a lot of the advocates. It would have been interesting to have a physician here today, because I am kind of set back by the discussion, and I don't want any family to go through what you went through. That's ridiculous that you had to go through that.
We still have to check every day when we go to the hospital. We have to pull her records.
Yeah, let him finish, and then we'll let you answer, ma'am.
Right, and I think that's really,
Go ahead, Representative Hewitt.
Chair.
Go ahead.
But I think that's real hard for a family to go through. I know that when we're looking at this on the EMS side, we need clear-cut orders, and this is why it would be great to have a physician in the room, because there is a protocol and a set that they have to go by when they're going through this. And I know with a child, that child has to be signed off clearly by their parents. And so it really sets me back on this, that we even have to do this. But Representative Knudsen, do you have you brought physicians? Have you talked to physicians? I think that's really where this is to make sure it's done within the state rules or law. I'm having trouble with this. So Representative Knudsen, can you kind of help me out here?
Sure. Representative Knudsen, go ahead, please.
Thank you, and thank you, Representative Hewitt. I have not spoken with any
doctors, I've spoken with nurses about this. And yes, this shouldn't happen, but this does happen. And this is proof that this does happen. So if it shouldn't happen, but it does happen, let's just make sure that it can't happen. That's what we're up against right now, and that's what we're trying to do. We're trying to make this so it can't happen.
Follow-up, Representative
Yes,
Hewitt?
one quick follow-up, Mr. Chair. And I think that this is going to be a hard vote because I think the language does not agree with some of the things that I'm seeing in a post. But I would welcome working with Representative Knudsen to make sure this never happens again on the post legislation that we have going for DNR, DNI, because I would never want this to happen not only to a child's family, but also to an adult or to a senior where we really bump into this, because these forms are needed. Unfortunately, it's the only way that I can go by the patient's wishes when I'm on a scene, and many times in the hospital, the same thing. So I would never want this to happen to another family, but I don't think this bill gets to where I would like it to join into the post bill. So that's my comments, Mr. Chair. Thank you for the indulgement.
Okay, Representative Franson.
Mr. Chair, I would like a roll call on this bill.
Okay,
please.
roll call has been requested. Did you have other comments on this, Representative Franson?
Representative Knudsen, thank you for bringing this bill forward. I had absolutely no idea that doctors themselves can put a DNR on and that parents have to fight to keep their own children alive. And I find that, well, shocking for one thing, but unbelievable in a state that believes that my body, my choice. So to the families up here, I want to thank you for making the time and for also advocating for your very precious children, because no matter where we are here in life, we are all valuable and we are all important, and we do contribute in one way or another to the state.
That's exactly what they told us, that she won't contribute. That's why they put the do not resuscitate order on her charge. What? No.
Okay, Representative Liebling, and then we'll take a vote.
Well, thank you, Mr. Chair. And I echo the sentiment, no one, what the families have described is really not acceptable. And, but I don't agree that if it shouldn't happen, but it does, then we should put a bunch of new law in place to make sure it never happens, because there are laws in place. And I just want to say clearly on the record that I believe this is an anti-abortion bill, very similar to the, what did you guys call it? The Born Alive Infant Act, which is really intended to demonize the medical profession. And something, doctors can misbehave just like anybody else. There can be really bad situations that come up, and they shouldn't happen, and those doctors should be punished. I guess I'd really like to know, did the families take any action to report the doctor to the medical board, to sue a hospital or anything like that? Because those are the kinds of remedies that if a doctor misbehaves, and this certainly sounds like misbehavior, those remedies should be used. But to put in place a bunch of extra law and regulation, and I didn't hear, Mr. Chair, if this was going to go to where this was going. Is it going?
Judicial.
It is going to judiciary, because it has things in it that absolutely would need to go there. But, it really sounds to me an awful lot like what happened with the so-called Born Alive infant, something that maybe if it ever really happens, it happens extremely rarely, is then there's a whole bunch of legislation that's put in law that makes it look like there's some terrible thing going on in the medical profession, which there isn't. And the fact that you haven't talked to any doctors, and I didn't hear anything from hospitals either, I just think that, for me, this just is a hard no. And it's not because I don't think that these children are wonderful, and the families, I'm sorry that happened. That really should never happen. But this legislation, for me, is a hard no. Thanks, Mr. Chair.
Okay. Seeing no, I'm going to let you close statement. I am going to make a comment. Thank you for sharing your story. Lives matters. We need to put everything in law to protect all lives, period. Representative Knudsen, closing statement.
Thank you, Chair. Every child matters.
Amen.
To the vote.
With that, a roll call has been called. Members, again, this will be recommended and referred to the Committee of Judicial Finance and Civil Law. With that, roll call has been requested, and I am a yes.
Chair Bierman.
Bierman, no.
Vice Chair Nadeau. Vice Chair Nadeau. Vice Chair Reier.
Reier, no.
Representative Bonner.
No.
Representative Carroll.
No.
Representative DePel.
DePel votes aye.
Representative Elkins.
No.
Representative Franson.
Yes.
Representative Gillman.
Gillman, aye.
Representative Hewitt.
No.
Representative Keeler.
Keeler, no.
Representative Knudsen.
Yes.
Representative Lee.
No.
Representative Liebling.
No.
Representative Mahamoud.
No.
Representative Perryman.
Perryman, aye.
Representative Purcell.
Purcell, no.
Representative Rapinski.
Aye.
Representative Schomacker.
Aye.
Representative Van Binsbergen.
Yes.
Representative Zelenstakar.
Selesnikar, aye.
Vice Chair Nadeau.
We have 10, so we have 10 ayes and 11 nays. It did not, the motion for House File 4568 does not prevail. Members, we're going to sneak one more bill in, and it's, we got a 5-minute grace period. House File 2291, Representative Mahamoud, I'm sorry. Okay, you got 5 minutes.
I'm moving fast.
I know, I try. You would like to move House File 2291 to get it before the committee, correct?
Yes, Chair,
Okay.
thank you.
Representative moves House File 2291 to be recommended and to be referred to the Committee of Ways and Means. We have the bill in front of us. Brief thing about the bill, and then our two testifiers.
Okay, I will keep it brief. Thank you, Chair, and thank you, committee members. House File 2291 would continue funding for Minnesota's Palliative Care Advisory Council, which would be $44,000 a year for 26 and 27. So I want to thank Representative Perryman, Co-Chair Bierman, Representative Elkins, and Rep. Carroll for co-authoring this bill. And quickly, I will turn it over to our testifiers to explain what this bill does and the council.
We're going to do Amanda West, 90 seconds. Go ahead, you have the floor, Amanda.
Thank you, Mr. Chair and members of the committee. My name is Amanda West. I am the Associate Director of the Minnesota Center for Healthcare Ethics and Chair of Minnesota's Palliative Care Advisory Council. I want to thank you for hearing this bill to continue the council's funding for fiscal years 2026 and 27. While all council members are volunteers, this funding provides extremely valuable administrative support from the Department of Health. Many people think palliative care is only given at the end of life, but it is much broader than that. It focuses on reducing the symptoms, pain, and stress that come with serious illness. It is appropriate for people of any age and at any stage of serious illness, and it can be provided while people are still receiving curative treatments. It focuses on working collaboratively to identify and promote patient goals of care and support family and other caregivers. We know palliative care means fewer emergency room visits, fewer days in intensive care, better pain management, and fewer hospital readmissions after discharge. Also, studies have shown that early access to palliative care can prolong patients' lives while promoting their well-being. Thank you for your consideration.
Thank you, Amanda. We have Ryan Hampton. Go ahead, please.
Good afternoon, Chair Backer, Chair Bierman, and members of the committee. My name is Ryan Hamilton. I serve as the legislative liaison for the Catholic Health Association of Minnesota, or CHAMN. CHAMN represents Catholic hospitals, long-term care facilities, and health systems across our state. Together, our members serve patients in communities large and small, including many rural areas, and are united by a shared commitment to advancing access to high-quality, person-centered care for all Minnesotans, especially those who are most vulnerable. Thank you for the opportunity to testify in support of House File 2291. Thank you, Representative Mahamoud, for your leadership on this issue. As we've heard, palliative care is one of the most important but often misunderstood parts of our healthcare system. Despite its benefits, access to palliative care remains uneven across Minnesota, and many patients, particularly in rural and underserved communities, do not receive this care
30-second
early
warning.
enough or at all. By strengthening the state's Palliative Care Advisory Council, this bill will help Minnesota better identify gaps in access, support workforce development, and expand high-quality palliative care across all settings. The council brings together expertise, coordination without creating unnecessary burden, and it positions Minnesota to make informed, data-driven decisions going forward. We also know that palliative care helps avoid unwanted or unnecessary interventions, making it not only person-centered, but also fiscally responsible. And CHAMN believes that this bill moves us closer to ensuring that any Minnesotan facing serious illness has access to care that is centered on honoring their dignity. And we respectfully encourage your support for House File 2291. Thank you.
I understand, Representative, we have a A1 amendment that makes some technical changes. What else would you like to say about that amendment?
That is it. It's a very simple technical change. We're just updating the years from last year.
Okay, Representative Mahamoud moves that the amendment labeled as A1 be put on the, I made a mistake here. Is there any discussions to the A1 amendment? Okay, seeing no discussions, all in favor of passing the A1 amendment, say aye.
Aye.
Aye. All opposed? Motion carries. Further discussion on this bill? Final words.
This is a great bill, guys. They're doing amazing work on this council. Please support this bill.
Okay, so House File, make sure we got the right number. House File 2291 be recommended as amended to Ways and Means, that's right. So House File will be, too much going on, okay. House File 2291 as amended to the General Register. Ways and Means, excuse me, Ways and Means. All those in favor say aye. Aye. All opposed? Motion prevails and it passes.
Thank you.
And then we have House File 45. Yeah, 4547, Bierman. Yes, let's do it. We got time, just do it quick. You can do it right there.
No, we can do it right here. I mean, you can just take
it.
Ms. Stearns, do the walkthrough for the file and.
Mr. Chair, Representative, or Co-Chair Bierman.
Can't hear you.
Can you hear me better?
Yes.
Okay. Mr. Chair and members, the 4547 is a forecast appropriations bill. It is purely technical. It implements the forecast for February to get the appropriations in alignment with current law, and that is all it does. It doesn't have any policy, or it's never amended, so it's a very straightforward thing. And we typically, we can either lay it over or
We will lay it
move
over.
it to Ways and Means, so yes.
We are laying it over, so with if there's no objections, we will take House File 4547 and lay it over. So that bill has been laid over. Members, we are adjourned.